thank you everyone for joining. And again, welcome to the Health Sciences talk series and also a new academic semester. We all hope that this semester and this year will be better and for all of us. And it's a pleasure actually today to start this semester with a very timely and important topic where Dr. Jamaluddine will be presenting most recent estimates of mortality in the Gaza Strip. And these are findings that are fresh from the oven, as you will see with the recent publication in The Lancet. Zeina Jamaluddine is an assistant professor at the London School of Hygiene and Tropical Medicine, where she earned her PhD in epidemiology just recently. She led the establishment of a birth cohort of nearly 1 million Palestinian refugees by linking electronic health and education records across 5 settings. This cohort enabled her to study long-term health trajectories and outcomes among this vulnerable population. Her research encompasses mortality estimation, nutritional assessment, and food security analysis in conflict zones. Dr. Jamaluddine, the floor is yours. Dr. Jamaluddine is gonna present for about 40 to 45 minutes, and we will have, inshallah, plenty of time for Q&A at the end. We will open the floor for Q&A, but if you also have any questions that you'd like to put in the chat, we'll be monitoring the chat as well. Zeina?
Hello, everyone. Can you all hear me? All good?
Yes.
Okay. So I'm very glad to be here today with the Faculty of Health Sciences. I consider this my second home, actually. And so I'll be discussing a topic about assessing the scale of mortality in the Gaza Strip and how the past more than a year at this point has been in terms of mortality estimation in Gaza and using different methods in conflict-affected settings. And I'll go at the beginning from what happened after October 7th and later on the recent recapture analysis and some projections to try to understand what, in terms of mortality, what we tried to really capture from all of the different analyses. So I'll start off a bit by the health information system at the Ministry of Health in Gaza. Maybe it's important to start with the fact that on October 25th of 2023, the President of the United States said that he has no confidence in the numbers that the Palestinians are using. And this has created a huge media and questioning of the numbers that was not there at that point until he made it very public. And so the Ministry of Health in Gaza released a listing of those who were killed from the 7th of October to the 26th of October. And it's important to point out that Gaza had very good electronic health systems of recording mortalities within hospitals. So what they actually did is that they would have the ID of the person killed, they'd have their first name, father's name, grandfather's name, family name, where they were killed, and also when they were killed, and the age and the gender of the person. So these electronic health records were used during COVID-19 and during other mortality, to assess mortality in Gaza previously, but they were able quickly at the beginning of the war to release this list to show that they were at that point around 7,000 that were killed. This enabled the different researchers to come up with different analyses to showcase that the numbers are correct. And we actually did this quite quickly to show that the IDs of the individual that were killed were actually, we see a pattern with them, with the registration. But also what we also saw is basically mortality of the population that looked like a population pyramid, in fact, of Gaza, where we could see that children, if you look at the ages here and the percentage between male and female, we could see that, in fact, there was quite a lot of children and women that were killed in the first 20 days of the war. But it's important to say that the whole focus on women and children has been quite a lot, and this concept of a perfect victim that everyone wants to put in the media of women and children and elderly, and also men are victim in this where they are going to get assistance or getting food, and so you could clearly see that the mortality in Gaza in the first 20 days was quite indiscriminatory. Then we actually did a bit of the normal mortality rate that we tend to do in epidemiology, where we have the ages of the people who were killed. Here we're talking about 0, that means they are under 1 year old. And then we have the mortality rate per 1,000 population. And what we also did is look at the male mortality in blue and the female mortality in red, but then later on also compared it to the mortality rates in 2021, which is usually the normal pattern of mortality that we expect to see. And then we also looked at mortality rate and how they look like for UNRWA staff, so the UN agency that works with Palestinian refugees, and also among healthcare workers. And we could see that among healthcare workers, it was a bit higher, the mortality rate. And so we were at the beginning trying to prove, and different people have tried with different ways to show that the mortality at the beginning were quite high, but also that it's important that the Ministry of Health data is reliable. Air Wars has done some investigation. There's quite a few within the UN who tried to show that these people, yes, they exist, these numbers are true. There's no reason to actually not believe the Ministry of Health records. Then what happened during the war is that the numbers were really questioned again, big time, when the reporting changed. And what do I mean by this is that the UN has reported that 26,000 at that point were killed, but then what they mention is that only 24,000 were actually identified. So they had the sex, the gender, the age of only 24,000. And that there were separately more than 10,000 between the Palestinian Red Crescent and between different agencies, saying that there are 10,000 that were missing under the rubble. And this created another questioning by the media, by people, of who are the unidentified? Can we really trust the numbers of the ministry? Are they an inflation? And here, what we were trying to say to everyone is this. What the idea was that what we saw in the war is in October 2023, and as time passed, in blue is the mortality names of those that were coming from the hospital morgue. So the first list that we talked about was in dark blue, was the names of those that were coming from hospital morgues that were killed. In what we see is with the first attack on Al Shifa Hospital, we start seeing this element of gray where we have those that are unidentified. So we don't have names, we don't have the details, but the ministry was getting data from the media, from different people telling them there are 5 bodies in Al Shifa Hospital. And it's important to note that the Shifa Hospital was actually the main center for data gathering. So when the attack happened and the center actually got shifted to another hospital, Nasser, and then Nasser Hospital was attacked, healthcare systems collapsed, and recording the mortality became harder and harder. And what I tried to show is that in the beginning, 9 out of 9 hospitals were reporting, then 6 out of 9, then 5 out of 9, then 3 out of 9, then 2 out of 9. Then they were able to pick up back again to 3 out of 9, then 5 out of 9. But again, if we continue this pattern, we will see that it goes back down. And so the ministry, what they tried to do at that point is to do some surveys and to try to say, okay, we are going to ask people to report in a survey everyone who was killed. And what they tried to do is start to put in with the mortality list, a list from the survey. So this is where the whole questioning of the unidentified happened. And where we were thinking that it's possible to start doing some of the elements that were done in other wars. And this is where I get to capture, recapture. So capture-recapture method is apparently now one that everyone probably is Googling, which is interesting, but because everyone became an expert in the past 3 days. But what I want to say is that it is a statistical method that's quite old, that ecologists have used a lot. And I will explain how they've done a bit of that. But also it's been used in previous trials and previous wars. So in the trial of the former president in the wars in Kosovo, Yugoslavia, these methods have been quite used. Patrick Ball, if anyone wants to go over what he has done, he's actually detailed quite a lot of the methods and pioneered quite a lot of it. They've also used it in Colombia to assess mortalities from violence, but also like different elements. They also did it in Guatemala and has been used in the trials in Guatemala. More recently, there has been assessments using in Sudan and in Yemen to do capture-recapture methods. And the idea behind it is that if we go to a place and we go to an area where there's not a lot of war and everything is fine, and we do this assessment of mortality, we might be really not understanding the whole picture, right? So we have a selection bias. And so the fact is that in war, there's a very big possibility of selection bias. And so using multiple systems or multiple lists or this capture-recapture from different listings helps in understanding the concept of avoiding some of these aspects that arise during conflicts. And so this is where I will go a bit into the very, very basic concept of capture-recapture. So the concept behind it is that it is possible to really understand the total population if we understand the ratio that is captured between two lists. So this is super simple, super simplified. So if we have in list 1, basically, and in a list 2, and if we have 2 people captured in list 1 and 2, what we do is that the ratio that's captured between list 1 and 2, so 2 out of 6, is actually equivalent to the ratio between the ones that are in list 2, okay, to the entire population. So those that are not captured. So it's like 2 out of 6 and 4 out of the n, and so you get the n as this. I know it's a bit like very, very, very simplified to say this, but if you want to think about it, and this is how ecologists have done it, is that they, and of course I'm not comparing people to fish, but this is what they've done, is they have a ponds and they have fish in it. They capture one day a group, they tag them, and then they release them back. The next day, they recapture a group and they count how many were actually tagged. And the idea behind it is that if you have more fish that were tagged, that means your total population is actually smaller. And if you have less fish that were tagged, your total population is actually bigger. Now, there are different assumptions in this, and of course, there are this dependency and homogeneity, but also this is where different people have talked about the need for 3 different lists, but also, of course, of doing models to take into account the interactions between the lists. So it is what we end up doing is actually fitting a generalized linear models, and mainly in the analysis we've done was a Poisson one, to actually look at how many were actually not captured by any list. And so this is a very, very simplified way of saying all of that, but I invite everyone to go into what Patrick Ball has really written, Francesco Cecchi has written about this method, but also many other ecologists, but for mortality estimation, I think these are the 2 big people who have really done it in different war settings. So the idea that we ended up doing is that we do have 3 lists. The first list that we relied on was the hospital list. And these were actually included the names of the people who were killed, including the first name, the father's name, the grandfather's name, and the family name. And that, to be very honest, is one of the reasons why it's a bit, I'm sorry to say it this way, easier to do capture recapture in Gaza versus doing it in Sudan. Because I know from the teams who did it in Sudan, the naming is not that specific. So they have tribes and different elements of how they put the names. But in Gaza and in our setting, also Lebanon is the same. The naming was the fact that helped also in capture recapture, and I'll explain why. So we have the name, and then we have the ID, and then we have the date that they were killed, the gender, and the age. This is the only first page of the hospital list, but you can see like all of them in this list were under 1 year old. So we have a listing from the hospital of those who were named. We have a listing from the social media, from the survey, I'm so sorry, from the survey. So what we did is actually ask the ministry for the raw data of the information entered by the relatives of those who were killed. So I have a brother, I have a sister, a son, daughter who was killed. You enter them as the ID, the first name, the father name, date that they were killed, where they were killed. And this information that the ministry was using, they were different types of cleaning, but what we did is actually get the very raw data of it. So because everyone in Gaza was asked to fill this, we were able to actually ask for whether it's possible to share that. And so we have a hospital list, we have a survey list, finally we have a social media list. I'm pretty sure maybe most of you have seen some of these. There has been multiple pages of that try to remember and talk about the people who were with pictures and with stories and with where they were killed and a lot of information. And so what we do is actually gather from X, Twitter, and Instagram, different obituary pages on Facebook to get the information of mortality. It's quite, to be honest, this was the hardest one to do because as epidemiologists, we see these names, and at a certain point, this is like an interruption of them. But just to say that we see these names, but when we look at the social media, we hear the stories of the people who were killed, and we scraped this data. So we now have 3 different lists, and these lists, what we do is it's very important to clean them individually. So you don't want in the hospital list 2 people of the same name, right? You don't want in the survey list 2 people that are duplicates. And so we clean each list on its own. And then what we did is we removed the duplicates first. In the survey list, we did something that it's we could discuss it further, but what we did is we removed those that were reported as missing, but they did not know if they were dead. So if you were under the rubble and you're reported as under the rubble, killed, we included them. But if a person is missing and might be detained, so the Israeli have detained them, or they are missing within the Gaza Strip, they're not able to access them, or they might be dead. And in this case, these numbers, we remove them because it is possible that they are alive, but we do not know. And this is an issue also with international ICRC have dealt with a lot in terms of missing and dead, and are they missing, are they dead? So hopefully they're alive and they will be released, but we know, like, we removed them from the analysis. And finally, we only included in the social media list, basically, we had a few cases where they were not traumatic injuries, death, and we removed them. And the reason why was because we, in the hospital and the survey list, were really focused only on traumatic injury based on the Ministry of Health reporting. So the Ministry of Health is saying these are traumatic deaths. So the idea behind it is that what I mentioned before is that we want to see the overlaps between the three different lists. So the name of the person and how well they overlap and how much they overlap between the hospital and the survey list and hospital and social media list to come up with the estimates of how many are unidentified. And that's where the names actually are very important. And the matching is based on name and age and sex, location, and month of them being killed. Then we did a bit of descriptives based on the data sets we have. So we have at the beginning quite a lot of mortality at the beginning of the war. But what we saw is that this is just looking at the list of names we have identified. This is not the ones that are unidentified. And so we see different patterns. And what it's important to talk about here is that it is possible to adjust in the model for to deal with the heterogeneity issue is to put the covariates in the model. So we do include age and sex as a covariate. We also did include month and did different analyses, and some of those are available in the appendix. So we want to deal with this issue of heterogeneity. So you adjust in the model for age and sex based on the different lists. So what I mentioned is that we looked at the overlap, and actually the majority, like more than 50% of the social media list, was actually included in the hospital or in the survey list. Now these are the percentage, and what you see is actually based on the total number. But if you look at within the social media list, based on the two others, you'd find that half of them are actually captured. And then the social media list has the survey list has less being captured by the hospital list. And the hospital list were actually the largest number names and all of that information. And so, as I mentioned, we did Poisson regression Poisson models to actually look at basically what happens whether you're in a hospital list, so one hospital list, 0 survey and social media. You could be in a hospital, you could be in the survey, or you could be in the social media list. You could be in the hospital and the survey. You could be in the survey and the social media, or hospital and social media, and then all three of them. And the idea is that all of these alternative log linear models that you're doing, you're putting the probability in being in one list, and then you put interaction terms, and basically to deal with all issues of dependency, and you adjust for the models for age and sex and different issues to deal with the heterogeneity. So and at the end, but also we do not pick one model. We actually rely on the posterior probabilities to do weight, okay, and to come up with how many are outside any list. And so, maybe some have seen the reporting is that by June 2024, the Ministry of Health was saying that the mortality was around 37,000. The estimate is around 64,000. That means that the Ministry of Health has an underreporting of around 40%. And this number that everyone took without looking at any confidence interval and looking at the fact that this is it. This is also models, right? So we need to think of the fact that it's between the 55,000, 78,000. I think in terms of epidemiology and the public, this is a whole different discussion, but I'm sure in COVID-19 this has been an issue. But the main topic and the point out is that that the number is much higher from what the Ministry of Health is saying. And that is 3% of the Gaza's population that's being killed, and that is 1 in 35 inhabitants in Gaza that was killed by Israeli attacks in Gaza. And so quite a lot, actually, if you compare to other conflicts. And if you see later on, because we, as I mentioned, we did adjust for age and sex, we had to come up with 15 age brackets because of the sample. And the idea is that if we want to go much smaller, we would have so much little data in cells. So we had to go with 15 age brackets of that. So then we could see the age, the annualized age mortality per 1,000 among males, and then among females, and you could see quite a flat line among females, where in fact, if you look at mortality rates in the Rwanda genocide and others, you'd see that flat rates. The other issue is that within males, what you also see is also a potential targeting of males that happened, especially for 30 to 44 years, where they can be combatants, but they also can be people who were going out to get food, and especially young people were trying to get food. They were attacked, and we've seen multiple reports of that. They might be they might be the ones moving more than women, more likely to be targeted at different times of the war. And so the annualized rate of the mortality, if you look at it on epidemiology term, is like 39.3 per 1,000 population people, and the rate ratio is 14, which is like you're compared to 2022. After the war, if you look at an annualized age mortality, you're 14 times more likely to die in Gaza. And if you look at it by age groups, also it's possible. It is possible that some of these mortalities are not only traumatic, okay, because we do rely on the fact that the Ministry of Health says they are traumatic and non-traumatic. They're only traumatic, I mean. Sorry, the Ministry of Health says that they are traumatic, but it is possible that some of them are non-traumatic. It's not, we cannot know if, let's say, one person comes to the hospital, has a heart attack, if in reality, how much are they distinguishing with them? And it also could be questioned also because they're all the effect of the war, the total collapse of the healthcare system. But the main thing is that we do not have a cause of death, but it is, I would assume there has been some, but not many non-traumatic injuries, and we do include that in the paper. So this is where I get into a bit the indirect effects or the excess mortality from non-traumatic injuries. And I'll be quick and maybe have 10 minutes at the end to talk about the projections that we've done. Now, also some people decided that projections are predictions, and that's completely not the case, I think. And it's what we wanted, and this is we tried to do that back in February. And why we did that is, I don't know if you remember, but in December, the attack on Al-Shifa hospital was actually one at the beginning, and then different hospitals were starting to be attacked. And the question of how many are dying due to the fact that they're not able to access care, but also what are going to be the big public health concerns in Gaza. So this was, we've done this analysis in February. At that point, we've done it between London School and Hopkins University. We wanted to model 3 different scenarios. So what would happen in case of a ceasefire, and we were hoping for a ceasefire back in February. Then a status quo, which was like at the beginning of the war between October and December, if it continued the same way. The escalation was a Rafah incursion at that point. This was before Rafah was actually they went into Rafah. So we wanted to understand the projections of different traumatic and non-traumatic injuries. There is a link for this that we've done with around 50-page method if anyone wants to go over them. Of course, these are not predictions. These are just projections based on different assumptions. And the question was to really understand what are the big public health concerns. And as we know that people in wars die because of aerial ground invasions and attacks, but also the fact that you have poor shelter, disruption of healthcare services, and insufficient water, insufficient food. The increase in acute malnutrition that we've seen in Gaza can lead to the idea of the indirect effect of the war and excess mortality. The big one that maybe Ghana can discuss even further are epidemics. Epidemics, or other people also maybe in the call, but I see Ghana here, could lead to extremely high excess mortality from infectious diseases if a cholera outbreak happens or different elements, if vaccination goes down a lot. So this is where we had we modeled in case of an epidemic with and without. Now, all these models, of course, could always be improved. This was a quick attempt that we've done, and I think gives an idea of where the mortality is in Gaza with different diseases, and maybe could always fix all of these models, and I'll get to that reason later. So we did model traumatic injuries, infectious diseases, airdrops and fecal oral transmission, and then we did look at epidemics, whether cholera. At that point, there was no cholera in Gaza, cholera and different types of potential infectious diseases. We looked at the indirect effect of the war from women and children, and mainly women, not being able to get antenatal care, but later on deliver in hospitals and get life-saving intervention. So this is not newborns who were killed because of trauma, but rather the fact that a newborn is actually premature, needs access to NICU, does not have an access to that, and how much mortality is going to increase because of that. And we did examine stillbirth and NCDs. NCDs was actually one of the hardest one to do. And so we have different assumptions, but also we only looked at acute events like heart attacks, cancer. We had ischemic stroke, the chronic kidney diseases in Lebanon and in Gaza. Actually, they're the first ones who actually get affected in terms of NCDs we saw, and we only did type 1 diabetes. It is not a full model, and I say that in Gaza, NCDs was before the war one of the leading causes of death, but also quite prevalent, and I do think that this is where a lot of the mortality might also be coming that we are not accounting for. We did model acute malnutrition also because it's an underlying cause to all of them. And then you rely on different factors and that we know that are determinants of different scenarios. So basically we relied on data of how many person per toilet, so crowding that was available, the size of the shelters, how many health systems disruption has there been RS, so has there been access to inpatient services, and in all different three scenarios, the ceasefire, the status quo, and the escalation, you put numbers and assumptions. We had data a bit on the status quo, and then you do assumptions for the ceasefire and for the escalation scenario. And you say, okay, now we have around 70 to 80% are living in shelters, for example. In escalation, that would be more. In a ceasefire, it might be less, but still people will not have houses to go to. The same thing with different elements. This is an idea. This is not everything we put. But we have done different models. The infectious disease model was done mainly in-house by Francesco, and different inputs from different people who've done actually work also on the COVID-19 projections at the school. And so the first thing that was done was actually a dynamic cohort model to track immunity, to understand so how much vaccination is decreasing and how much this is going to lead to increased infectious diseases. Now, the idea really is that Gaza had 100% vaccination. And so it is decreasing and immunity is changing. And so we did that dynamic model. We did some expert elicitation to put inputs into the model to look at case fatality ratios from the literature, but also from experts. And later on, what we find also is that the big endemic infections that were really causes of death in Gaza would be COVID-19, influenza, and pneumococcal diseases. We had also later on done projections using for epidemics, and we find the big issue about epidemic is that you have high uncertainty. So do you have cholera in Gaza? And if a cholera outbreak happens in Gaza, the upper limit can actually reach 120,000 killed. And whereas if we do not have a cholera outbreak, it can be zero from cholera. So it's actually like this. We looked at what is the probability of having an epidemic with more than 100 deaths. So measles were the key big ones. Polio, this was before the polio outbreak that we saw. So the experts have told us that big worries in Gaza were measles, polio, and cholera. And I do think that, and meningitis, and I do think that these are still big threats in Gaza. Then we did the projections of acute maternal and newborn based on the fact that they're not able to access care. So you're not able to breastfeed your child, you're not able to get antenatal care access, or not able to get healthcare, childbirth care. We have, as I mentioned, that, for example, it's that during the status quo, 80% of women were able to access healthcare facility to deliver. In a ceasefire scenario, more will be able to. In an escalation, less will be able to. And so we use these inputs to basically do the model. This model actually is available and has been used a lot by Hopkins and others, but it's it's very straightforward to do. And this was the only model that we didn't have to create from scratch. It uses the LifeSafe tool, but what we do is actually we look at how many lives were actually killed. And we do find that if you find in gray how many they were killed from before the war. So before the war, how many would have been would die. So we know that maternal mortality is never zero. And so we do have and the same thing with neonatal death and stillbirth deaths in gray. But then we look at the models with the ceasefire scenario, with the status quo, and with the escalation. But maternal mortality is actually not the biggest, but it leads to around 50, I think, at that point during 6 months of projections. But the key indicator that we look at is maternal mortality ratios, that actually we see levels of healthcare that go back 10 to 20 years in Gaza. And so if we compare to numbers from 1995 and like these numbers, this is what we find in Gaza. And so this is a reversion of the healthcare system. The big mortality comes from also neonatal, because they're premature kids and they have very high risks, especially if they're not having access to NICUs. We've seen in the news also children dying because of all of the hypothermia and all of the aspects that we've seen recently. And later on, we finally did the NCDs one. The NCDs one was also based on a few. I do think that COPD, like the pulmonary diseases one, might be really high, but we have not included it, mainly because they're smelling all of this, the dust, and this will have triggered a crisis, but also would have probably led to high patients who have COPD to have excess mortality due to that. The other aspect was that you have a heart attack, you can go to hospital, get treated, but you're not treated, and so their mortality. The issue with the NCDs is that it's more complex than what we've put, but we try to just understand what we have with the data we have. So, okay, we have data about type 1 diabetic who do not have access to insulin, and what is their survival? And so we rely on these. Now, the biggest mortality was from ischemic heart diseases and from strokes, but also from kidney diseases. What I also mentioned is that because it takes a lot of time for healthcare systems to get back doctors and basically all the equipment needed for all of this, even with the ceasefire scenario, these are going to be biggest causes of death, but because of the fact that like you need for ischemic heart diseases, for stroke, specialized doctors. They have been killed, they have been targeted, they have left Gaza, some of them, but also the healthcare system, the hospitals, and I think most of the audience here knows what I'm talking about. So I'm finally gonna talk about, hopefully, I'm very hopeful for a ceasefire scenario. So at that point of the projections, when we did them, we were saying 74,000 lives could be saved, and this many lives could be saved if we do a ceasefire. Today, we're hoping for a ceasefire scenario, but I would say that the majority of the excess death is going to come from infectious diseases, especially if an epidemic happens. And within a ceasefire scenario, around 6,000 people, there's projected 6,000 people who might die due to the different aspects that I said about the healthcare system. And the next, when we modeled it was for 6 months, so within 6 months. And I think it's important to prepare for this now that the war ended, but the effect of the war on mortality is going to still be ongoing. And I think we all sort of know that in terms of public health. Finally, I did talk a lot about numbers and all of that, and I do think that it is very important for all of us to remember that these are people behind the numbers. We have Dr. Abdul Karim, who was killed, who's an OBGYN. There is Dr. Sufyan, who actually was the president of the Islamic University in Gaza, Salma, and many other kids who were killed, and Saad, and many other journalists. And hopefully we hear a ceasefire soon in Gaza, but the effect of all of that is going to still be going. And I'll just finish with a poem from Hiba, who was killed at age 32, who's also a nutritionist like me. And she says that one day all gardens sprouted from our names, from what remains of heart yearning, not just passing. And just want to finish with that Hiba and all the others that we've talked about as numbers are people behind all of these numbers, and it's important to remember them all. And thank you so much.
Thank you so much, Dr. Zeina, for this comprehensive yet heartbreaking presentation. As you said, every number counts and every life matters. This is quite interesting. I'm just going to open the floor for questions now. I'm just going to mention before we start this Q&A that is also quite interesting that you studied the post effect of war, not just like the people affected by like a trauma injuries, because actually there's quite an interesting study that you might be interested in. Is it's done by Brown University. It's called How Death Outlives War. So it talks about that this war in the Middle East that was for over 2 decades, it killed almost 4.5 million people. 3.5 of them, so just like 1 million were killed in the fighting, but 3.5 were killed in the post effect of war. So you could tell the scale of, you know, the impact of this war for years to come. I'm just gonna see if anyone have a question. You could kind of either raise your hand, or you could just like type it in the chat. So so there's like a note from Jocelyn that this is a wonderful presentation, Zeina. Okay, so let me see if any questions.
Thank you, Jocelyn.
Okay, so Dr. Nuwayhid, so would you please just unmute yourself and then ask your question?
Yeah, thank you, Zeina. I concur. It's a wonderful presentation. Great work, Zeina. It's refreshing that you're doing all of this and putting evidence next to all of this. So, and thanks for your reminding us of the people behind those numbers. Zeina, can you explain a little bit more the survey? I didn't get how this survey was conducted. So was this a regular survey that we talk about household, or this is just explain that a little bit, because the numbers were less than the hospitals actually. So the other thing, looking back at the projections that the two schools, Hopkins and the London School did, how close they were to reality, or is it still premature to assess that? So these projections that we always work with, can you test them to check whether you were close or far from the reality? Thank you.
Thank you, Dr. Nuwayhid. First of all, the survey. The survey was conducted as a normal survey that was circulated within Gaza with a form that people entered on different information of those who were killed. Now, it was sent around also on different platforms, on Telegram mainly, because this is what people in Gaza tended to use. And they asked people to fill in the survey. The numbers that were coming from that survey, and the ministry was trying to get some of the idea of trying to bridge the gap between the unidentified. What was very essential for us to do is actually get the raw data of the survey and to like understand the overlaps between the survey and the hospital. So how many people are reported in two lists? But the survey was circulated as an exactly normal survey that not asking people to report who was killed, but not asking people in the past year, how many people do you know who were killed for? No, it was asking people the names of the people who were killed, the idea of the people who was killed, and whether they need a certificate, a death certificate. So it was more of a listing. So you could open it today and enter this data to say, X person was killed, this is where they were killed, this is what their age is. And also at the end, it asks you to put data about who is reporting. So I am the mom of the person who was killed, and so on. This is the survey. But it wasn't like what we saw in Iraq. So the Iraq mortality survey was different. The second question that you asked about projections, I think this is the big question that is people who worked on COVID-19 have discussed and continue discussing. I do think that in terms of the indirect effect of the war, whether NCDs, I do think for NCDs, our models are underestimates. And whether maternal mortality, newborn mortality, I'm seeing some data coming from UNRWA. It's a bit similar to what we've projected. But in terms of the traumatic one, this one is completely not the case. And because what we did for a traumatic one is that we used the pattern in the beginning of the war to come up with later on. And the patterns of wars are not consistent. Like you can't see like a linear regression in all of that. And so I do think that what we tried to do in the ceasefire scenario is more relevant in injuries, because what we did is we looked at ordnance and we looked at injuries and how long injuries and treatment and that happens. So in the ceasefire scenario, the mortality is going to come also from injuries that are not treated. But at the very, very, very beginning of the war, the bombing was quite a lot and led to a lot of death in few days. And so using that to later on do the 6 months for traumatic one, how much it matched with what we have, I do not think that's the case. But in terms of epidemics, in terms of NCDs, in terms of chronic diseases, I don't think we have this today, but we should be doing surveys, hopefully when a ceasefire happens. First of all, for understanding needs and assessments, but I think we sort of understand what are the needs: food, medicine, hospital. But for mortality, I think this one is a lot of people are pushing for it. So maybe they would have a better assessment. Very long answer, sorry.
Thank you, Zeina.
Okay, thank you. Any other question? So please, like, just feel free to raise your hand, or maybe you could kind of type it in the chat and I would just read it.
I
Okay.
actually have a question to Zeina. Thank you, Zeina, for the incredible work, really, and presentation. My question is there any data on the number of combatants in these lists? Do we know? I mean, there's obviously lots of women and children, but from the men?
This is the favorite question of media. And
I'm sorry, but I think it comes to the mind of people.
I will say that we do not have that information. Air Wars does not have that. And like, if you look at different investigations done by Air Wars, they've done a very nice analysis also at the beginning of the war. And there is another UN report that was done. We do not know. We do not know how many combatants and non-combatants there are. This is why people are focusing on men that are age 15 to 44. Or all of that aspect of, because even the debate of if a child is 18 years old and all of that also comes. And anyway, I don't want to get into that. But the thing is that I want to emphasize on is that the men are the one who are going to get food assistance, and they're the one who are also going to, and we saw that, and so. But not only that, but in hospitals, we've seen a lot of doctors, that there are female doctors who are very brave and were there also, and there are brave doctors that have been working, and also first aid respondents, and this pattern we do see that there is higher. If you look at the pattern across the whole population, it's high for everyone. But there is definitely a targeting of these 14 to 44. There might be combatants, yes, I'm not saying no, but they also might be people who are going for assistance and work. And also, there is a recent report, I think, in Harris about the indiscriminate killing of men in different areas. And so I do think that there has been different reports that say that, but this is the question that everyone wants to ask.
All right. Actually, I do have a question myself. I was working on, I'm working on similar data with the Ministry of Health in Lebanon, and I had this meeting this morning on, how would they be able to kind of assess those who are killed with no specific, unknown gender or unknown age. And some of the people, like where the ministry was talking this morning, like some were in pieces, so they're not sure, but these are casualties of war. So they should be accounted because they were kind of, they died because of the war, so they should be accounted for. So how do they kind of work around these challenges?
Now it depends. You could do like imputation if you want, and this is
No, I mean, like in your study, like did you get this data complete, or these types of mortality were not accounted for?
So these would form into the unidentified. So these would be basically the one that you would capture, when they are outside any lists. I do think that the Ministry of Health in Lebanon had, I'm not sure, but you might know better, had very good mortality tracking, but it is also possible to do multiple system estimation, like the capture-recapture methods, if we believe that we need to have different lists, because the ministry list alone is not reliable. I'm happy to advise if you ever want to have these discussions, but I do think that the ministry was able to really every day put out these statistics. Maybe I'm wrong, but if there is some missing information we've done in terms of age and sex, so we know the names, but we don't know the age. It's possible in epidemiology to do like imputations, and we've done that.
But you just included all these. Okay, perfect.
Yeah.
Okay, so any questions? Anyway, if you have any questions, you could kind of communicate. If you have Dr. Zeina, if you kind of share your email, they could kind of communicate with you any further questions later on. So thank you so much, everyone, for your participation. Thank you, Dr. Zeina, for this really heartbreaking presentation. Yet it's absolutely essential with all this kind of rigorous and research approach in this kind of unusual circumstances. Thank you again, and then we'll see you in the next talk. Take care. Have a good day. Bye-bye.
Thank you, everyone.